Welcome. This lecture we will cover pediatric cardiovascular dysfunction. So I plan to go over basic cardiac anatomy, quickly review the transitional cardiac changes at birth, discuss the impact of defects, and talk a bit about care of the child with congestive heart failure and hypoxemia. Let's take a look at the heart. Okay, so you've got 4 chambers and 4 valves, and the blood travels from the superior inferior vena cava to the right atrium, to the tricuspid valve, to the right ventricle, to the pulmonary valve, which goes to the pulmonary artery and to the lungs where it picks up oxygen, to the pulmonary veins, left atrium, mitral valve, left ventricle, aortic valve, aorta, to the body. If this is still unclear from what you learned in fundamentals and med-surg, make sure that you review it, because really understanding the flow of blood through the heart can really help make a lot of this content easier to understand. Okay, take it from me, who had to actually go through and learn all of this really for the first time in a long time in order to teach it. Understanding this part really is crucial. So another important thing to be aware of is that fetal circulation is different than neonatal circulation, and these differences are going to help you understand why certain defects exist. So babies do not breathe. They're like little scuba divers, right? So their oxygen has to come from somewhere. It wouldn't be super useful for their blood to travel to non-functioning lungs. So it has to bypass the lungs to get oxygen from the placenta, okay? The fetal heart has its own little pulmonary bypass system in order to do this. So here's how it works. The unoxygenated blood comes into the heart as normal through the superior vena cava. But as you can see here, most of the heart is actually filled with oxygenated blood instead of being split in half that you would see in like that normal human heart on the right. So how do we manage that? Trapdoors, my friends. The placenta is connected to the inferior vena cava via the ductus venosus. So as the systemic blood returns, it forks into the oxygenated blood coming from the placenta and mixes in that right atria. And so now all that blood in there is oxygenated because no lungs, right? At this point, some's going to go down into the right ventricle, but some will go through the foramen ovale into the left atrium, and then the left ventricle, and then out to the body. But Taylor, some of you may say, the right ventricle still connects to the pulmonary arteries. What happens there? Well, very detail-oriented student, the vessels near the lungs are actually super small right now, so the pressure is higher than it is near the heart. And so much of the blood will then shunt up through the ductus arteriosus directly into the aorta. About 8% of it will still get to the lungs, and that serves to perfuse the organs so that they can develop and prepare for their grand entrance. Once that blood is circulated, the umbilical arteries will take it back to the placenta to be enriched with oxygen again. So voila, fetal circulation, okay? So now the whole performance I just gave really isn't necessary to memorize, so go ahead with your collective sighs of relief. However, it helps, like I said, to put all of the rest of this lecture into context, okay? So those trapdoors I talked about, the foramen ovale and the ductus arteriosus, they can get a bit stubborn after birth. They will close on a bit of a delayed schedule. Newborns will often have a murmur as a result, and then after a few days, the fetal prostaglandin levels will drop and those shunts should close. Spoiler alert, some, however, do not. So, quick physiology review before we move on. Cardiac output equals heart rate times stroke volume. So how fast you are pumping multiplied by the amount that is in each pump. Preload is the volume of blood returning to the heart, while afterload is the resistance against which the ventricles have to pump when they are ejecting it to the body. So more volume in a ventricle equals more afterload, right? Contractility is the strength of the heart. How well is it pumping? Moving on. So we can test cardiac function in several ways, and most of this should be review for you. If any of these terms are muddy, just please take some time to review them. Cardiac cath is the one thing that we're going to be discussing for a bit. So when you're having a catheterization, that catheter is placed at the femoral artery and is guided up to the right side of the heart through the aorta. And so this results in a minimally invasive method for accessing the heart, right? So we can do several things with a cardiac catheterization. For one, it's a great diagnostic tool. We can measure pressures and oxygen saturations internally, or we can visualize the anatomic structures as we would with an echo. It does provide some benefits over an echo in that it is more accurate for some issues like pulmonary hypertension or to allow for a simultaneous repair, but echoes are definitely less invasive and a cheaper procedure. Number two, Or number 3, actually, they can take biopsies and place stents and valves during a cardiac catheterization. So they can also be used for ablation in the case of an arrhythmia or to clear clogs. So it's like healthcare's drain snake, all right? When caring for a patient who's undergoing a catheterization, which comes up a lot in exams, our primary focus is on hemodynamic stability, okay? We just trailblazed through an artery. So prior to the procedure, we're gonna be checking all the typical pre-op sort of things. With peds, diaper rash is another consideration because of its location. It can be a source of infection if we try to enter the bloodstream via a yeasty area of the leg. They should also be NPO for 6 hours or so. This procedure often uses dye, so we'll also want to be screening for iodine allergies due to the use of the contrast. Post-procedure is a common testing item as well. We want to focus on that pressure dressing to ensure there's no arterial bleeding. So these kids need to stay supine for several hours to both prevent bleeding and maintain their hemodynamics. Vitals are going to be checked frequently. We also need to monitor the extremities for perfusion, checking temp and color as well as those pulses. And then pain management is going to be crucial as well. So let's get into heart disease. Congenital heart defects are fairly common. They occur in about 1 out of 100 children, and it is also the leading cause of birth defect-related death. Many of these children do go undiagnosed due to a lack of symptoms, but about 25% are critical enough to require interventions within the first year. So while about 15% of defects are genetic, other factors contribute as well. The critical time for fetal heart development is between 5 to 8 weeks. And that's usually before most pregnant people know they're pregnant, right? So familial risks, exposures, genetic background can all play a part, and there's not always a clear answer to the cause. An exception would be a chromosomal abnormality like trisomy 21, as it's been very well studied. And we know that about 1/3 of these kids will have a defect. So therefore, all of those children are going to have an echo, okay? While there's rarely a definitive cause of a defect, there are several maternal factors that can contribute. And I've listed a few of them here. As you can see, many are uncontrollable and dependent on situation and circumstance. If someone's taking medications that are known to cause an increased risk of cardiac defects, they will often pivot to a less risky medication if able during pregnancy, but this is not always possible. So we can categorize our defects into a few different subcategories, and these are defined by the effects of the defect. So some can cause more blood flow to the lungs, like a congestive heart failure would. Some can obstruct the flow from the ventricles. And if the blood cannot get to the lungs, we'll see hypoxia. If it cannot get out of the heart into the systemic circulation, we're going to be backing up in the lungs, causing those CHF symptoms. We can also have decreased flow to the lungs, which can be also secondary to an obstruction, right? And then there are mixed defects that affect pretty much everything. So an important concept to remember when talking about circulation can be illustrated by this photo, which is that the blood preferentially flows to the path of least resistance. Okay, that can help out a lot when trying to visualize these things. So I broke down the 4 categories that I just mentioned, but there's actually 2 major categories that hold these 4 in their buckets: acyanotic or cyanotic, red or blue. And this is based on the ability of oxygen to circulate through the body. So we will begin with acyanotic conditions, which can be split into those that result in increased pulmonary blood flow or those that obstruct blood flow from the ventricles.